Hello, everyone, and welcome to the first in a planned series of webinars sponsored by Dystonia International, formerly National Spasmodic Dysphonia Association. I am truly delighted that we have Dr. Robert Bastian with us today as the person who's going to kick off our webinar series. And we are looking forward to the session today. Dr. Bastian obtained his MD from Washington University in St. Louis and has practiced laryngology since 1987. He founded and is director of the Bastian Voice Institute in Downers Grove, Illinois. Dr. Bastian is an internationally recognized authority on the treatment of voice, airway, swallowing, and coughing disorders. He is the recipient of the Honor Award for Teaching Contributions to the American Academy of Otolaryngology, and in 2010 received the AAO Distinguished Service Award. Dr. Bastian has served for many years as chairman of our medical advisory board. And I am really pleased and I'm privileged and honored to have known Dr. Bastian and worked with him for more than 20 years. So let me just quickly do one housekeeping item, and I will turn it over to Dr. Bastian, and that is we welcome and want your questions. So please type in your questions, and we will answer as many of those as time will permit today. If we do not get to all of the questions, Dr. Bastian has graciously agreed to answer those for us, and then we will put those questions and answers up on our website. So this is your opportunity to ask lots of questions, and with that, Dr. Bastian.
Okay. First of all, thank you very much for inviting me, Charlie and Kim. It's been great to work with you across the years. And the idea, I'm going to go ahead and share my screen right off the bat here. There we go. The idea that I was asked to cover is to give you a little tour of voice disorders and then focus on spasmodic dysphonia. So I remember my first trip to Europe many years ago. I thought maybe I'd never have a chance to return. So I did one of those 7 countries in 5 days kind of things. And so I feel like a little bit like that. We're just going to have to give you a little taste of the other voice disorders because I do want to get on to spasmodic dysphonia. So first thing I need to say, whoops, what's my... There we go. First thing I wanted to say is a big thank you to NSDA, now Dystonia International. When I started working with spasmodic dysphonia, it was common for people to go for many, many years undiagnosed. And across my career, the time from onset of symptoms to diagnosis has dramatically shortened. And I think that's due in no small part to the work of Dystonia International. So a big shout out. And I send my patients not infrequently to Dystonia International, NSDA, because of the tremendous resource they are for the spasmodic dysphonia community. Kim is always, and Charlie are always ready to help. So a big shout out there. There is another resource that you might know about, which is my personal teaching website. It's called laryngopedia.com. And on there, you can also find information about spasmodic dysphonia. There's quite a lot there just for those interested, and you have to scroll down to see some photos and videos. Well, we're going to orient you very quickly to what it is we're talking about, the vocal cords or the larynx. So here you see the cutaway and turn to the side. The vocal cord is right here. And so that's just the orientation. Here are vocal cords up close. It's like a fold of tissue or a shelf of tissue, stretched long for high notes and flattened for low notes, just like a rubber band is. And just to point out that the larynx, the voice box, is really a transducer. It takes pulmonary air from the lungs, and converts it into acoustical energy. So it's a vibrating source. Just to give you another quick look at how we're, where it is that we're actually looking at, we're going to stand on top of the tongue here on the left side, and we're going to walk backwards, and we're going to bend over and look down at the interior. So here you see we're just beginning to see the larynx come into view here, and then rotating a little farther. Here is the larynx sitting down in the middle of the neck, in the throat. The swallowing passage is behind. And then here you see even more closely, the larynx does its work. The vocal cords are down inside here, and they do their work in the dark, which is such a shame, such a loss, but it's such an interesting mechanism. And behind the larynx is where the swallowing passage occurs. So here I'm representing swallowing passage at rest, or swallowing a little bit of saliva. And then when you chew your big bite of a Big Mac, it enlarges to allow that food in. So here are the vocal cords up close. And the way we look at them is either with a telescope that looks at 90 degrees, or with a fibroscope that looks end on, but through a flexible device. So the larynx has a skeletal system, but what we're more, and that's what we appreciate on the outside, the voice box, the Adam's apple, the Eve's apple, but it's the interior, the soft tissues of the larynx that are really responsible for making voice. There are 7 paired muscles, and there's 1 unpaired muscle, and all of those have to work in this remarkably, this finesse kind of way in order to produce a normal voice. So looking from the top, you can see the vocal cords are inhabited by muscle, and then there's a surface covering that does the actual vibrating. It's not really the muscles that vibrate, it's the surface tissue. The mucosa we talk of is really the covering of the vocal cords. So buried inside these vocal cords is the muscle, but the surface tissue is called mucosa. Just as skin covers the outside of us, mucosa covers the inside. It's in our nose, mouth, throat, lungs, GI tract. That's all lined by mucosa. And that mucosa has to be very flexible, just like the skin of my hand. I can stretch it and pull it without really moving my hand very much. That surface tissue of the vocal cords has to be able to vibrate. And I'm showing you the flexibility of it here in these surgical photos. So this is 1 cycle of vibration at A2. So there's you notice the vocal cords are closed. They're not in that open position. They're completely in this closed position in both pictures here, but they're separating with each vibration. So at A, below middle C, that's 110 times each second. It does that little apart and together, open and closed phase. It's quite remarkable. So that's why under standard light, it's a blur. So just to show you how vibration occurs, a quick look at vibration. Now that's not a perfectly normal larynx, because they should close all the way during each cycle of vibration, but that's getting rid of the blur with a strobe light to see individual vibrations. And you notice all the wetness. It is a wet place down there, and that's all for the good. So a quick tour now of some other voice disorders other than spasmodic dysphonia. I just picked a few of them. There are so many, I couldn't really cover them all, but a lot of voice disorders are what we call vibration injuries. So just as if I take my hand, which is covered with skin, and it's designed for what it does, for friction, I can shovel in the garden, but if I go beyond a certain point, I'm going to get injury to my skin, blister, callus kind of thing. In the same way, if we use our voice too much, too loud, too aggressively, we can develop injury of that surface tissue, not the muscle or the ligament or the joints, but just the surface tissue. Papilloma, cancer, and paralysis, just some examples. These are vocal nodules. So the person you hear on TV or in the mall, or who sounds kind of hoarse, and you observe them for a little while, and they're just a live wire, and they're maybe a little loud spoken, and they're very talkative. And well, those people will sometimes develop these little swellings. This is the point of maximal vibratory stress. And that's why the little injury occurs right there. This person would have a quite normal speaking voice, but if she, in this case, tried to sing a very clear high note, they would sound hoarse. And so in an opera singer, this would be a big problem. In a person who doesn't sing, they might not even know that they're there. Here are bigger paravocal nodules, and they're vibration injuries. The shearing and collision forces create those injuries, those elevations, as a protection. Capillary ectasia, you see abnormal vessels, which make the vocal cord more vulnerable to the stresses of vibration. Here you see a broad-based swelling, and you almost always see the greater swelling on the side of the greater ectasia. So it's a vulnerability issue. Here, this is an ectatic capillary that has burst and it's bruised. And so you see the residual of the bruise from, say, 10 days earlier is still visible. And these are blurred because these are vibrating. These vocal cords are in the course, and it's not strobe light. So that's why you just see a blur. Polyps, this might be the kind of thing you would see after a sporting event, a very intense competitive spectator who's very vocal and doing a lot of very loud use of voice. They could develop abrupt hoarseness and a little polyp like this. This happens to be a gospel singer who has sung for many years with a great deal of intensity and vigor and verve. And she's just developed this kind of giant polyp that gives her voice a very rough quality, but surprisingly, she can still kind of sing with that voice, but it's a very rough sounding voice. Here is a closer up picture that the vocal cord can develop a sort of blood blister idea. And then when the blood absorbs away, sometimes this is a different person, the opposite vocal cord, when the blood absorbs away, sometimes we're left with a polyp like that. So these are very simple injuries. They create a laryngitis kind of thing, loss of high notes. Here's a cyst. You see this white sphere. Here's another white sphere. Not all of these, but most of these are vibration injuries. Here you see this sort of mottled appearance, and you see that there's an open cyst. You can kind of see there's a little divot or a little opening there, and that white debris is partially spilling out, but not completely emptying. Here's one that's a little more subtle. If you look carefully, you can see this little slit right here, and I'm using a little instrument to open it up. That's called a sulcus. That used to be a cyst, and then it emptied out all of its contents to leave that pocket behind. This is called a mucosal bridge. This is called a furrow, like a furrow in a farmer's field. You can see there's kind of a depression, and there's an upper lip and a lower lip. So a lot of these are vibration injuries. This one is smoker's polyps. If you're in a public place and you hear this kind of unusual voice behind you, it's kind of a really deep, very deep, hyper-masculine voice, and you turn around and there's a 70-year-old woman who looks like she's 5 feet tall and weighs 100 pounds, but there's this extremely deep, hyper-masculine voice. That would be smoker's polyps, usually seen in a subset of smokers who are also very sociable and talkative. Paralysis. So you can see right here, some of you may have known someone who had polio in their youth. Polio is kind of becoming very uncommon, but if you ever saw someone in shorts and you see this normal sized leg and this very thin leg, that's because the muscles have wasted away. And in this paralysis picture, you remember I showed you the muscle that inhabits the vocal cord. Well, here that muscle has atrophied away. And so you have an inability to pinch the vocal cords together in a very weak vocal quality. Here you see papilloma. You might have heard of human papillomavirus or HPV. So this is a papilloma, not a cancer on a vocal cord. This is before treatment, and here is after treatment. And this, of course, is a cancer. I dealt with something quite a bit like that this very morning in the operating room, smoker's disease primarily. Okay, and then muscular tension dysphonia. I could probably spend about 20 minutes talking just about MTD, because has become so enmeshed in the story of SD, and in my view, inappropriately. By the way, I'm a person who loves alternate opinions and different points of view, so I have no problem with people thinking of this differently than I do, but I also do like to press my own case fairly vigorously. So I would say that MTD has become enmeshed in the story of SD inappropriately, because MTD, as I think it should be thought of, is a functional disorder. It's basically bad posturing, and it's amenable to speech therapy, but it is very difficult. It is not an easy speech therapy fix. It is not neurological, it is functional. And I'll get into what some people call MTD in the SD world, that I think is not MTD, but is instead a tonic variant of spasmodic dysphonia. And I'll explain what is a tonic variant. I'll explain that in a minute. So now, finally, to spasmodic dysphonia. And first, a simple definition. I think everyone on this call is probably quite well versed on the disorder, but just in case, dystonia, the prefix dys means abnormal. Tonia is tone or muscle tone, and dysphonia, same prefix, abnormal. Phonia is sound. So dystonia in the larynx creates dysphonia. And since almost all cases of laryngeal dystonia cause spasmodic dysphonia, the terms have become somewhat interchangeable. They're not technically, but because about 97% of laryngeal dystonia causes dysphonia, that's why the two terms become so interchanged. So this abnormal tone in the muscles can be sustained. That's what I call the tonic variant, or it can be twisting and repetitive, and that plays into the phenomenology of the voice. The manifestations in the voice vary based on whether it's a sustained kind of dystonia or a more twisting and repetitive kind of dystonia. So you are all familiar with government that's local, state, or federal. Well, dystonia can sort of be local, state, or federal, but we call the local focal. So the eyes, the larynx, the neck, the limb, the jaw. So if those are found mostly in isolation, that would be a focal, meaning one place, dystonia. Regional is when someone might have some affecting facial muscles, jaw, and neck. It's kind of a region of the body is involved with dystonia. And then generalized, mostly seen early onset, early in life, generalized, where kind of all of the muscles of the body are twisting and have abnormal tone. And the focal, you can have, I think, multifocal, because there are people who have larynx and hand. Well, I can't really call that regional, so I would say that's kind of multifocal. So SD, spasmodic dysphonia, laryngeal dystonia, is a focal dystonia. So examples of the focal dystonia: ocular, so that's eye dystonia or ocular dystonia, also known as blepharospasm. So you see this blinking kind of thing happening where the person is blinking in a way that is exaggerated. That's ocular dystonia. Cervical is the neck, where the head is turned or tipped or in some way kind of, that's also called torticollis. Actually, there's anticollis and retro, but anyway, I tend to just say cervical dystonia. Limb or arm dystonia, writer's cramp, the hand that works well for putting on glasses, for combing hair, but you take a pen and the hand begins to kind of jerk and do things that you don't want it to do. That's limb dystonia. And then laryngeal dystonia or vocal cord dystonia, spasmodic dysphonia. Well, to get a picture of what's happening when a person has laryngeal dystonia, I'll just show you these two pictures for the big distinction, which is adductory and abductory. So adductory, the vocal cords are being added together too hard. They're adducting too hard. So here you see the same larynx that's phonating in a fairly typical appearance. So when I go E, I look sort of like that. It's blurring because it's ongoing, but in my voice, E, you wouldn't see a lot of movement. I could almost make it look like a photograph because I can be so stable. But in persons with dystonia, there are these sudden spasms. This spasm that I'm showing you, this is an actual spasm in a person with ST. You can see that the larynx is clamped shut, and that's what's responsible for those interruptions of the voice. I'm going to mimic some phenomenology as we go along. Or if this is a posture that is sort of sustained, then you're going to have what some people call the MTD variant, but I think should just be called tonic variant. Because remember, the dystonic, the tone abnormality can be sustained, or the tone abnormality can be kind of jerking and changing. And that is what, so here, the bottom two pictures is an example of the abductory spasm. So this person is going with a somewhat breathy voice, and then suddenly the spasms pull those vocal cords apart, vibration stops, and it drops to a whisper. So you go and the voice just goes away for that brief moment. Well, the characteristics of dystonia, I would consider these things sort of a given more than an opportunity. Some people look at these things and they say, oh, this gives me an opportunity to take control, to get involved, and it can seem psychogenic, so I'll go and see a psychologist, and maybe managing stress in my life will. And I would say, well, certainly do that if you have other reasons to go for treatment of anxiety or whatever, but don't do it purely for your voice, thinking that this is a psychogenic disorder. It is not. It is neurological. It is not psychological, in my opinion, in any way. Now, psychological states affect symptoms, but psychological states affect how well I sign my name. If I'm hurried and stressed, I just don't write as clearly. If I have high blood pressure, psychological states are going to affect my high blood pressure. If I even have diabetes, if I'm going through a period of great stress, it may actually change my need for insulin. But my high blood pressure isn't psychological. It's not a psychogenic disorder. So that's why I say I think it sometimes rests people with SD to say, this is just a given of SD. I don't bear any responsibility for this. And it can be strangely task specific. A person can go in their chest voice, and in their falsetto, they go, and it's like remarkably less affecting. Now, that's not everybody. Some are equal in chest and falsetto, but that's just an example of what I mean by this task specificity. Certain sounds don't work as well as others. When I pick up the phone, I've learned to say, the phone rings, I pick it up and say yes. I don't say hello, because hello just doesn't work for me. Sensory tricks, the idea that I can put my thumb under my chin, I can raise my eyebrows, I can do, I can tap on my forehead, I can do various things and sort of distract the dystonia. Those are called sensory tricks. The variability, it's just a given. Some people want to hyperanalyze. Why was my voice good this morning and so bad this afternoon? And I personally say, well, do whatever analysis you want, but it can rest you to say, hey, that's just a given. I'm not really responsible for those moments that it really acts up. It's just a given. It's part of SD. Why does SD seem psychogenic to some? Because the onset may have occurred at a time of great stress, but you take 100 people and you map out the stress of their lives. Human life has so much stress, everything under the sun, job loss, your house burns down, there's a problem with a family member, there's all kinds of stresses. So sometimes SD sort of manifests itself at a time of great stress, and so people mistakenly say, aha, this is a psychological or a stress disorder. I really do not think it is. Another reason is that stress and fatigue can make it worse. But again, I would just tell you about high blood pressure and diabetes and all of that. It doesn't mean it's a psychological or a psychogenic disorder. It's neurological. And then there are the subliminal messages that people receive from others. You go visit your cousin, you chat for a few minutes, and your cousin says, "Oh, yeah, can I get you with a kind of a look of concern, can I get you a drink?" And what they're sending through their body language is, you're not doing so well, and I need to kind of come to your comfort. And so sometimes people absorb subliminal messages from others that it's a stress disorder. It is not. Well, how is it diagnosed? Personal opinion through the history. That's what the person, one of you, would tell me your story, and out of your story, I would glean information that helps me say, I think this is SD. The voice characteristics, you've noticed I've underlined it because that is a critical part of the diagnosis. And that's why you need a diagnostician who is good at voice, at mimicking a good set of ears. They can kind of have you do simple things with your voice to help classify and verify the diagnosis. And then laryngeal examination really in a lot of ways is the least important. It's really the history and the voice, in my opinion. Now, there are people who do a lot of objective measures, measurement of sound waves and airflow and so forth. That all is interesting, and there are places that do more of that than other places. I personally think it's not. These three things are necessary. You have to do all three of these, and they are sufficient when done well by a really skilled examiner. Well, what is the typical history? It's unremitting once established. Now, there are people who have periods of time where they say, sometimes it's normal. And I will say to them, now, are you saying it's like normal? Or are you saying it's absolute? Well, no, it's not normal, but it's just so much better that I sort of almost consider it normal. So typically it's unremitting once established, though it can vary a lot. Variable symptoms: stress makes it worse, fatigue makes it worse, alcohol makes it better. They hate the telephone. I would say 97% of people say, I just hate the telephone, drive up windows. There's something about the use of a telephone that it's almost the worst circumstance for people. So when I hear that, I'll say, tell me about the telephone. Oh, I hate the telephone. It's a strong indicator. Especially difficult sounds. People say, I can't say numbers. Sometimes people say, it's hard for me to say my name. Numbers are hard. The word hello. It may be easier to sing, and a history of misdiagnosis. I've been told I have acid reflux, especially if a person is fairly early in their onset of symptoms, and maybe it hasn't fully settled in, and they'll be given the wrong diagnosis. And again, thanks to Dysphonia International, NSDA, that's happening a lot less often. I classify according to the voice manifestations: adductory, vocal cords pushing together too hard, added together, adducted, about 90%, abductory, about 10%. That's where the vocal cords jerk apart, about 10%. There's a group that are mixed. They have a little of both. There's atypical variants, which I'll mimic in a minute, and with or without tremor. So when I see a new patient, I might say moderately severe adductory spasmodic dysphonia with no tremor. Or sometimes I'll say with T, and I'll make the lowercase t, and sometimes I'll say a moderately severe adductory spasmodic dysphonia with capital T, to say, the tremor is more evident in this voice. And sometimes I make the capital T very large, meaning this person has laryngeal dystonia, but the tremor is almost what they lead with. That's almost more obvious than the spasms are. And then with or without tremor, and then 97% are phonatory, and about a few percent are respiratory, and I'll tell you what that's about. So again, I'm reminding you of the little spasms that occur. either this happens in a sudden moment and then let's go, or it's a sustained. Classic phonatory arrests, what are they? That's the stoppages, the grabs, the catching of the voice. Long ago, people thought that was easier to travel. I'm doing a lot of phonatory arrests there. It was easier to travel and those are phonatory arrests. Non-dysphonic but tight, a tonic variant. I've seen just a few out of maybe 1,500 people career long. I've seen just a few whose voices sound kind of like this. So you wouldn't really necessarily say this person is hoarse, but you hear the tightness and it's very tonic. In other words, the squeezing is sort of stable squeezing. Or you could have this and an occasional phonatory arrest. So I would classify that as adductory spasmodic dysphonia, tonic variant with occasional phonatory arrests. There's a tight vocal fry. It's sort of like this. Long ago, people found that it was easier to travel. And you notice I'm not doing a lot of phonatory arrests, but I could have this tight vocal fry kind of quality and add in some phonatory arrests. So you see, I would describe that as adductory tonic variant, or sometimes I call it fry variant, vocal fry variant with occasional phonatory arrests. Cry variant, once in a while, the pitch goes up and a person sounds a little like they're going to cry or they're crying, but they can be kind of, again, tonic, not necessarily with all those arrests. They sound a little like this, where people say, with this kind of a variant, they say, I get so tired of people saying to me, are you okay? What's up? Like on the phone, that sounds emotional to people. And that's why I call it the cry variant. And you could have this cry variant with occasional phonatory arrests also. So you could have there's the strain component or the tonic component, and then there's the arrest component. There's even a stage whisper. We're still on adductory, but a few times I've seen this misdiagnosed as abductory because the voice is sort of whispered like this. But what you're hearing is the tightness in that voice. So because it sounds whispery, people will sometimes say, oh, that's abductory, but it is not. That is adductory. And so you can have this kind of a voice and occasional phonatory arrests. So you see how we describe it according to its phenomenology. And then with or without tremor. So let me give you just an example or two with and without tremor. So adductory, sort of a classic variant with phonatory arrests and some strain. Long ago, people found that it was easier to travel on water than on land. That would be kind of classic without tremor. Now add tremor. Long ago, people found that it was easier to travel on water than on land. So you hear the tremor underlying there, but you may not really hear it very clearly unless you have sustained. And then you hear in the classic phonatory without tremor, you might hear, but if with the classic phonatory and tremor, you might hear, so you hear the unsteadiness. So with or without tremor. Once in a while, you'll hear almost pure tremor. It's very obvious tremor, and you have to listen very carefully to say, is there any spasm in there? So if I do pure tremor, I might be, long ago, people found that it was easier to travel on water than on land. And so that's just pure tremor. That's essential voice tremor. And sustained is like that. But I'll do now one where it's primarily tremor, but there's an occasional spasm. You'll hear this little interruption. Long ago, people found that it was easier to travel on water than on land. They needed a clear path or road. So you can hear the little interruptions that stop the tremor a little bit. So I would call that spasmodic dysphonia adductory, and I do the big capital T, meaning this person's voice phenomenology, they sort of lead with the tremor. Now, abductory varieties, those seem to me so far to be more simple. The classic is intermittent syllable dropouts. It's long ago, people found that it was easier to travel on water than on land. So you hear that a lot of the syllables are just dropping away to a whisper. And there is one that's a little bit more stable. It almost sounds like the person is whispering more continuously, that you don't hear quite as much of the dropouts to nothing. And then, of course, that could be with or without. And then respiratory, not very common, but that can be inspiratory or expiratory. So I'll make it really obvious and far more loud than it usually is. But the person, if it's inspiratory, will say, I can't fill. The airstream, instead of coming in this smooth flow, it comes in pieces, the inspiratory air. So you'll hear this, and I'm going to make it pretty loud. It goes kind of like this. So you hear I'm getting my air in little pieces. They can't fill. Expiratory, a little less common, is they can breathe in. So they're breathing out in little pieces. And sometimes you have to get very close and listen to someone's breathing up close before you can hear those. Anyway, so let's move on. Laryngeal findings, normal anatomical exam, but increased adductory tone. Actually, and tiny quivering or major spasms. Treatments, psychotherapy, medicines, voice therapy, Botox, I've capitalized because I still think it's the mainstay, and then various surgical options. And I wanted to leave more time to question and answer, so I'm going to try to hurry. The reason for options in general in medicine is something about patient preference and trade-offs. Every treatment option has its pros and its cons. So it's the trade-offs that sometimes lead people to pick one thing over another. Heterogeneity of the disorder. So, I've just mimicked a wide variety of individual cases of spasmodic dysphonia. And so the treatment for one person may not be as ideal as it is for another. Availability of the treatment and the clinician. You may not find every treatment available in every place. And the heterogeneity of response. If you sit in a waiting room in a Botox clinic for SD and two individuals who don't know each other compare notes, they're going to find out that they have different response to treatment. So not now and again, I've had a patient come in and say, I met so-and-so in the waiting room, and I want you to treat me like you do her, because she goes 20 weeks between injections, and I'm having to come back every 12 weeks. So can you do for me what you're doing for her? And the answer is, well, there's a heterogeneity of response. Some people have difficult anatomy, so there are just any number of reasons why you need options. Electromyographic, I'm just showing you here how the injection is done. What can patients contribute to their treatment success? Well, it's really important. I've mimicked a lot of things because I really like patients to understand clearly what is a Botox effect and what is spasm and what is tremor, because if you can master what's happening to your voice, you're better able to help your physician, give you better treatment. So spasm is either tightness like this, or tightness like this, or strain like that. And spasm is the cutting out of the voice. And tremor is the wavering. It's the shaking of the voice. And you need to clearly understand that versus Botox effect. I've had a few times where a person will come in and they've had their treatment, and they come in and they say, Dr. Bastian, I need more Botox. And I say, you were just injected a week ago. It was your first injection. Yes, and I'm here because I need more Botox. And it's like they are thinking that the voice disorder is not being handled by the Botox and they need more Botox. And the answer there, no, you're not understanding the difference between spasm and Botox effect. And that just like there are people who are colorblind, there are people who are tone deaf, there are people who have more trouble figuring out what is it that's really happening to my voice. And the better you are at explaining or understanding this is Botox effect, this is spasm, the better you can help the clinician. What else can you do? You can shop for high quality shots. You shop for produce, you shop for your car. So why shouldn't you shop for high quality shots? And you need to run the show. If you can do those three things, understand the phenomenology, shop for high quality shots, and understand that it's you that runs the show. It's your purposes that we're trying to meet. So it's perfectly okay for you to come in and say, I want half my usual dose, please. Well, why is that? I have board meetings next week and I don't want to do my usual week or 10 days of weakness. I need and I'll be happy to come in 10 weeks instead of my usual 16. Well, that's you running the show. What are the side effects of Botox for adductor? Breathiness. Breathiness is this kind of a quality. Weakness. I can't yell. When I try to yell, I can't. I don't go to restaurants because I can't talk. Short phonation time. Instead of talking a long time like I am right now, the very same breath of air, I'm still going on the same breath of air. I haven't yet taken a second breath of air. I'm talking for a long period of time. And now I can take a next breath and keep going. I have a kind of a short phonation time and I have to take a breath more often. I can't say as many words. That's a short phonation time. Or my voice goes kind of Minnie Mouse on me. It goes kind of high pitched. And sometimes it goes high pitched continuously. And sometimes I'm talking along like this and it cracks up into that falsetto voice. So that's a side effect. Now, for me, that would be more than I would be willing to accept. So I would be running the show and saying to my doctor, I need a smaller dose. Luffing is when the vocal cords kind of flap like that. They're flapping like a sail, a sailboat sail. And aspiration of liquids, usually a sign of a much too high dose. So it's not very common to get at that coughing on liquids, except with too high a dose. Abductory, the side effects are noisy inspiration. I cough, and that rapid inflow of air after a cough is noisy. My husband or my wife tells me that all night long I'm kind of moaning. I'm kind of sound asleep, going, and it doesn't bother me, but it keeps him or her awake. That's very common early after the abductory injection. Exertional noise. I'm quiet if I'm sitting and reading, but if I climb a flight or two of stairs, I get to the top of the stairs and I'm kind of going, and I feel a little short of breath. That, if that's present to any great degree, then the dose is too high. But I like a little of that. In fact, I ask people to practice going, so they breathe in as fast as they can. You notice you just heard the air rushing noise, and I want them to hear a little bit of a. So if you don't get any of that, the dose wasn't high enough or the target was missed. Reasons of discontinuation, the wrong diagnosis, primarily, functional disorders. Variable results. I'll tell you the story of a patient I inherited who said, Doctor, I've had 5 shots for my SD. The first one was amazing. The second one, nothing happened. The third one, nothing happened. The fourth one helped a little bit. And the fifth one, nothing happened. So that person I remember said, I just think Botox is a stupid treatment. Like who can deal with this? Well, that's a reason for discontinuation, but it's also the sign of what I would call sort of poor quality shots, because you need a somewhat consistent result. The pincushion experience, I'm all bruised and it's an ordeal and it hurts and that's violates the need for what I call a slick shot. So you need consistent results. There is variability. Nobody on earth can give you exactly the same results every time, but your results should be somewhat consistent. You can count on it working. It should be done in a way that's slick. It's not a pleasant experience, but it happens fast, and you have one little red dot and that's it. And persistent overdosage, I've had a few people say, well, I complain that I don't like that initial breathiness, and my doctor said, oh, it's part, you have to, that has to be done, that you have to have that because otherwise the Botox won't work. Well, that's persistent overdosage, and that makes people not that happy with their experience. What you need instead is noticeable weakness at the beginning, but your voice needs to be very functional for you. If you're struggling and you're dreading every shot because of this weakness and breathiness, and you can't eat in restaurants because nobody can hear you, then I'd say that's persistent overdosage. Now, if you're driving a tractor and you're in the cornfield and you're Clint Eastwood and you don't, then fine, you can go for a dose that's quite high, looking for adding a week or two on the end. But for most people, that would be overdosage. Logistical hassles leads people to discontinue. I live 7 hours from the nearest place that I can get Botox. Well, that's going to, and then patient biology. There is a small group of people who I say they have an effect from Botox, but they have very little benefit. I have 2 people right now where they get their injection, they have the weakness, it's very noticeable weakness, and they go almost straight from weakness back to spasm. So they almost have to be injected like every 6 or 8 weeks. And that is not a doctor thing, that's not a dose thing, that's a patient biology thing. Surgery, I wonder if we should just skip that. I'm really wanting to leave time for, somebody asked about focused ultrasound. You wouldn't come to me for precise information about that. I'm just not your guy. But basically, the idea is you focus multiple ultrasound beams on a part of the brain stem. You know how a microwave oven heats the molecules? Well, you can focus that kind of ultrasound energy to kind of heat up a part deep in the brain with very precise mapping using MRI. And basically you're trying to kind of create a little lesion in that area to interrupt the abnormal nerve impulses. Deep brain stimulation is a similar idea, but using electrodes rather than that kind of focused burn. SLAD-R is taking the nerve supply of these extrinsic muscles, the strap muscles. So there's a nerve branch that goes to that, and it's not usually affected by the dystonia. You make a window in the voice box underneath this muscle here, and you divide the nerve that goes to the adductory muscles and transfer the nerve from the strap muscles. So that's SLAD-R. Caveats about surgery: when there are multiple treatments for something, that usually means nothing is perfect. Otherwise, everybody would get that done. So just really, ask your questions and get another opinion and so forth. The dystonia tries to win, and I'm personifying the dystonia there, but I've learned over the years that you put a block in dystonia's way and it looks for a way around it. That's why the nerve section was so great for some people for a time, and then their symptoms came back. The dystonia kind of finds a way around. And I actually have wondered if that's one of the reasons that Botox keeps working, because the dystonia is working with a moving target. So the Botox works, the muscles go limp, and the dystonia starts to kind of figure out how it's going to, and then the Botox effect kind of fades away, and the dystonia says, okay, I guess I'll relax. And I'm sorry for the personification there, but I do think that moving target issue with Botox is part of the reason it continues to work. I think if you had a Botox injection that were permanent, that the dystonia might well find a way around it. There is some long-term evolution of dystonia. There are people who are treated very nicely for their SD for 10 years, 12 years, and then the Botox seems to stop working as well. But it's because the dystonia has evolved and they've added quite a bit of tremor. Tremor is not as well treated. Okay, I think we do have a little bit of time. So I wanted to end again with a big thank you to Dystonia International. I almost have to look down at my little note every time because I'm so used to saying NSDA. Tremendous resource. Call them, write them. When you need to find a source of treatment because of where you live, the first thing I would do is call Kim or go to their website, to this website, and that's where you're going to find the people in your area. And I tell people, check out not just the list of doctors, but check out the support groups, because support group leaders, they're in the know. So call the support group leader and just say, I'm new to the area. We have people who move to Florida or whatever. Just call that support group leader and say, who's the go-to person in my area? And don't be afraid to shop the doctor to find what I call high quality shots or treatment. All right, I think that's it for me. Should I stop share screen or what should I do?
Go to a few of the questions, Dr. Bastian.
Okay.
Let's start with one here. The person says, can you have both AD and AB?
Yes, you can. I referenced it very briefly. That's the mixed variant. So a person can do this. They can say, long ago, people found that it was easier to travel on water than on, so you're hearing both the dropouts and the grabs. So in that case, what I do is I treat the predominant spasm. And it's not just what I hear. So I've had some people where I hear more AD than I hear AB, but they will say, but the one that bothers me is the dropouts. And so we treat the kind that bothers people the most, or if they're not sure, the one that I hear the most of. And then once in a while, we'll try the other one, and then we will do both. So I have people where I treat both the AD and the AB. I do the shot for each kind at the same sitting.
Okay. Let's see, I'm just looking through your IPS. What are your thoughts on type 2 thyroplasty procedure done in Japan?
Well, remember my skepticism about surgical approaches, and I'm leaving DBS and the ultrasound out of that. I'm talking about structural or nerve sections. My skepticism about that, again, is that the dystonia tries to get around it. And in a practice such as mine, where I have such a large population, you can imagine that I've encountered people who have done everything under the sun. And I just, one of the problems with SD is, and I've said this many times over the years, every treatment works for somebody. So if you have a group of 80 people or 100 people, all who have SD, you may have an individual who, in fact, it's happened one time, we had an individual who said, I don't understand, why doesn't everybody use clonazepam? I use clonazepam and oh my goodness, it makes such a difference. And then frustrated hands go up and they'll say, but I've done it and all it did was make me sleepy. And so that's the trouble with the thyroplasties and with the nerve sections. And it is that, the little poem, there once was a girl who had a little curl right in the middle of her forehead. And when she was good, she was very, very good. And when she was bad, she was horrid. Is that a poem everyone knows? The idea is if we could see the future, I might say to you, wonderful, do a type 2 thyroplasty. You're the one that's going to get a good result. But I'm pretty skeptical of surgery that's structural and nerve. The SLADR, I think every option is on the table. I'm not, but I'm just urging a little caution.
Okay, good response. Let's see, here's a good question. It says, Primidone work for tremor?
Primidone for tremor, tremor, it's interesting, tremor with clear dystonia there are people who I always say to them, now I'm going to take care of your spasms, I may or may not take care of your tremor. So there are people though whose tremor sort of vanishes too, especially when the tremor isn't as evident. The tremor is very well managed. It's those ones where there's clear dystonia, but they're leading with this very big tremor. Those are the ones that I say it may be that we resolve the strain and the effort but you may still have a kind of a wavering voice. If it's pure tremor, essential voice tremor, I rely on my neurology colleagues to handle that. So primidone, Inderol, propranolol, and in severe cases where essential tremor is deep brain stimulation, I've seen some good results.
Another question says Botox hasn't worked for my AB. Are there any advances in neurological treatment?
Well, first a comment about the Botox. AB is one where in particular you have to find a skilled injector. And the way you can tell if you have had Botox shots, but you've never had that, you've never noticed anything of that sort. Your husband or wife doesn't ever say, or you don't find after you cough, there's a little inspiratory noise, then it may be the more correct way to describe your experience could be, I don't know whether Botox is any good for my abductory spasmodic dystonia because I'm not sure the target was ever hit. And especially when people come from laterally, which is the predominant method, I much prefer anterior, and I've written a little article on that. But when people come laterally, it's very common that the target is missed. There's no, and you just have a lot of swallowing issues. That's a common experience. So that doesn't necessarily mean Botox isn't your treatment. It may just mean we don't know because you've never had it in the right target. So, oh, by the way, if you want to know, you may know, obviously, from noises, climbing stairs and such, but if you're not sure, do that thing where you blow completely empty and then breathe in as fast as you can and compare it to a family or friend. Families and friends will be able to go, and you will go either hear that little bit of noise, that little bit of voice, or louder, or even a. So you have to have some level of that inspiratory noise, or they didn't hit the target.
And you've touched on this a couple of times, Dr. Bastian, but this person is saying, this is interesting, they're saying that they've received Botox for 32 years for adductor type with apparently good effects. However, the last 2 years, it stopped working completely. I do not have tremor. My MD has changed the Botox, yet it still has not helped. What can I do?
That's a hard one. The question there in my mind is if there is no effect. See, you distinguish between effect and benefit. So if you're getting shots, getting great results 32 years, now you're getting shots and there's no benefit, the very first question I want to know is, but is there an effect? Did anyone, who you didn't tell and they didn't see the little red dot, would anybody, and if they say no, that nothing happened, then I'd say, well, the question is whether you have an antibody or the target was totally missed. And I did have a patient one time who went through, had been treated successfully for a while, and then she said, it's not working for me anymore, and I injected her and got great results. So I don't know what the answer was there, because it was the same person, and it was a really good person, so I don't know. But apparently there is some evidence that a holiday from Botox for a year or so, it seems the antibodies can subside. So I wondered that. I don't remember the interval between when this person who came to me from out of state, I think it had been 9 months or something. So, but if Botox A doesn't work, then Botox B should work. So if neither of them works, I think it's just, I'd like to give it a try and see if it doesn't work. That's my question.
Okay. I think we'll wrap up with this last question comment, Dr. Bastian. This person said 3 years ago, I switched to Botox shots into my false vocal cords after more than 20 years of shots into my vocal cords. This approach is much more effective for me. Could you please explain the difference?
Yeah, I don't quite understand that personally. So you should take my answer with a grain of salt because I'm not someone who's done a whole bunch of false cord and true cord. I stick with the true cord. What that makes me wonder, the line of questioning I would pursue with that person is, number one, is it working better because you're not blown out of the water so much? In which case I'd say, well, I think there's a smaller effective dose that's probably still getting into your true cord. In effect, what happened was your dose was reduced. because the false vocal cords really are not inhabited by much in the way of muscle. And so that's why I've never understood it. It's why I don't do it, because, it doesn't make a lot of sense to me, but it could reduce the effective dose.
Okay. All right, Dr. Bastian, again, thank you so much. It's been a very, very informative session. Amazing how fast the time goes by.
Oh my goodness, I'm sorry I went so long, but
no, you did not. It was we're right on. We're right on. It's but your information is fantastic, and just a tremendous number of questions by people, and everyone is so appreciative of.
Well, maybe we should just do a pure Q&A. No.
Absolutely. So we'll wrap up, and I will say again to everyone, there were other questions that we did not get to. Dr. Bastian has graciously agreed to answer those, and then we will put those questions and answers up on our website along with the entire presentation, which has been recorded, so that information will be available to all of you on our website. So again, Dr. Bastian, thank you so much for not only this presentation, but all your help and support over the years, sir. We greatly
My pleasure.
So to everyone, thank you. We appreciate your attendance, participation, and look forward to seeing you hopefully next month on the next webinar. So long, everybody.
Bye-bye.